And I bring greetings from ILBS, which is a WHO collaborative center, on this important international webinar. Fatty liver origin of all NCDs. Why priority is needed. You all know the functions of the liver. I would like to highlight two things: that liver tolerates all till it fails. Failure means failure of regeneration. Liver controls your blood sugar. The pancreas makes insulin on the demand and supply from the liver. Fatty liver has to be understood in the context of normal liver. In normal liver, which is brown, maroon in color, about 1200 to 1500 grams, has less than 5% of its total weight as fat. If the fat increases to 10% or more, it is fatty liver, large, whitish. And this is due to surplus calories and sometimes due to the genes. NAFLD, which I will define in a minute, actually would drive the next century, as 1/4 of the world's population today has fatty liver. And borderline or true NASH, non-alcoholic steatohepatitis, which includes some hepatitis but later fibrosis, cirrhosis, and liver cancer. To give you a perspective, hepatitis B or C give about 2% annual incidence of liver cancer, while fatty liver can go as high as 13%. And there are several modifiers why it is increasing is because of the lifestyle, obesity, and others. This map published in Nature tells you countries which are above 30% of NAFLD prevalence. You can see India and several parts of Southeast Asia also come under 20 or 30% NAFLD. So we have a fatty liver pandemic. This slide developed by Dr. Kapil, considering India as 1376 million total population and above 18 as 816, even if you take 20%, not 30% of NAFLD, we have close to 163 million adult NAFLD cases. Compare that with B and C, this is almost 3.5 times. The presentation I focus today that fatty liver is the origin of all non-communicable diseases. And the bottom line message is the liver fat flames and then frames the rest of the organ and the body. So these slides will be repetitive for a while. Alcohol or fat, whenever they come, they will produce fat in the liver. Each of these cells, as shown in this liver biopsy, this is a normal cell, but this is a cell which has fat, white, globular, containing fat. This fat is called steatosis or fatty liver. However, body's immune system, the innate or adaptive, they do not like these cells. They think these are foreign cells. They have fat, they are unhealthy, they must be removed. To remove them, the T cells or DCs, dendritic cells, they will all work hard. So there is an inflammation here. These T cells would kill the hepatocytes which are with fat. This is steatohepatitis. This steatohepatitis, fat-induced hepatitis, will show up as increased ALT. Please remember this part. Then, to heal this up as a chronic wound healing, there will be some scar. And this is gradually leading to cirrhosis and sometimes to liver cancer. This is the journey of fat-induced hepatitis, fat-induced fibrosis, fat-induced cirrhosis, and cancers. Now, the second part of this extrahepatic is when there is fat in the liver, the insulin cannot enter. As I told you in the beginning, blood sugar is regulated by the liver cells. So if the insulin cannot enter and get the glucose to be metabolized for ATP production, there will be more and more insulin need. And this increased production of insulin over time by pancreas will lead to diabetes. This also leads to excessive fat in the liver to spill in the blood. That fat which is circulating in the blood, you go for your blood test. Oh, I have a high cholesterol, I have a high triglyceride. You start treating it without knowing that it has come from the liver, which is full of fat already. Remove the cause rather than just treat the cause. This high fat will actually settle first into the gallbladder, and you have gallstone, which is a liver disease. Then it will go to your arteries, you get atherosclerosis, heart disease, and stroke. This schematic diagram tells you what happens, the fat and your fatty tissue. So fat in the liver will go and release all these inflammatory cytokines. The macrophages carry this fat and the message of insulin resistance. So your adipose tissue, your fatty tissue is dysfunctional. I won't go into details, but there is a crosstalk all the time throughout the day between the liver and the fatty tissue. What it does, this dysfunctional adipose tissue and excessive fat leads to development of type 2 diabetes, hyperglycemia, hyperinsulinemia, and development of all inflammatory cytokines which are circulating. I've just shown you one part of it. So a liver which is metabolically burdened because of fat, excessive calories, this is a result of making your bacteria also bad, or the reverse can be true. Bacteria can make there is fat in the liver. Your adipose tissue is bad. The cells are active immune cells, cytokines, insulin resistance. So they lead to diabetes, heart disease, and lot of stroke and neurocognitive dysfunctions. This is just the beginning of the whole concept of how liver as a metabolic factory sends to different units different messages, and finally these units become as dysfunctional as the fat content is. Now, briefly, NAFLD to diabetes. This study, very old but famous, 129 non-alcoholic fatty liver disease patients were followed for about 14 years. 69 of 88 developed type 2 diabetes or impaired glucose tolerance. NAFLD increases risk of diabetes by 2 to 5 fold. What is important, and that is the basis of this whole webinar, is you regress the fatty liver and the risk becomes normal. The diabetic will lose need for anti-diabetic drugs, including insulin, if the fatty liver is reversed. This is a famous Framingham third generation study. I told you if there is fat in the liver, it is inflamed, ALT will be high. So these were young kids born to the Framingham cohort. Those kids who had high ALT had a risk of developing diabetes when they became adults 5 to 20 times. These studies show you several of these, the association of NAFLD to type 2 diabetes. So NAFLD raises the risk by 1.8 or 4.6, 5.5, blah, blah. So all these studies show there is an association and predisposition of NAFLD to development of diabetes. So I summarize the first part. Diabetes today should be looked at as a liver disease, and attempts to prevent should be done by reducing liver fat and inflammation, that is ALT. So your whole NCD program can and should have a relook that, yes, while you are trying to treat diabetes, but if you can prevent fatty liver or treat fatty liver, maybe we can decrease the burden of diabetes. Other organs. This very important study, which is the basis of all global studies today, 1,42,000 health insurance participants in Korea between 35 to 59 years. Their baseline ALT, liver inflammation, was measured between 90 and 92. They were followed for about 10 years. Those who had an ALT of less than 20 had all cause or liver related deaths as one relative risk of mortality. But as your ALT becomes 30 to 39, all countries generally have 40 as the upper limit. 39, your liver related ALT increase, liver related deaths are about 9.5 times. All other causes are also 1.7 times. But suppose a young man of 25 has an ALT or SGPT of 90. You can imagine his overall risk within next 10 years will be several fold higher. So the message is clear that not only liver, but almost all other causes of death are increased because of liver inflammation. At ILBS, we are following ALT of less than 30 for male and for female less than 19. This is what is also followed in the US, but better would be to have less than 20. ALT, marker of liver inflammation, correlates with, as I've shown, fatty liver disease, dyslipidemia, diabetes or risk of diabetes, hypertension, heart disease and risk of heart disease, all cancers and many, many more. Please check your ALT, and anybody who comes to your hospital, this is more important probably than your hemoglobin. ALT and intrahepatic triglyceride. What you are measuring is the circulating triglyceride. Oh, my triglyceride is 200. I take a drug. But what is the liver triglyceride? So just see plasma ALT. Your ALT is 100. What will happen? So somebody has an ALT of 100. There is so much of fatty liver. No NAFLD versus NAFLD. So higher the ALT, intrahepatic triglyceride is 25%. What you need is 5%. But what you are having is something close to 25%. So whenever you get your triglyceride done, please think that it is due to fatty liver. Whenever the ALT is high, it means the ALT of 80, you will have about 20% of liver fat. Even if the person has no fat, then there is a normal ALT, you can see that. But the moment there is fatty liver, a high TG will be having close correlation, and same is true for ALT. Coming to heart, NAFLD, this fat goes and gets deposited into the arteries. This is the media, this is the intima. This is the lumen. As the fat will deposit, the lumen will become smaller. Your arteries will become smaller. They will become hard. This is the fibrous cap. Over a period of time, a plaque will develop over this. The lumen gets obstructed. Any artery, this plaque gradually increases and then occludes. The blood flow becomes abnormal. Person gets hypertension. Person gets coronary artery disease. This is very clear. All this fat goes through macrophages to the arteries. The risk of acute myocardial infarction and stroke increases. This very large study of 120,000 patients with NAFLD and controlled groups. You can see that age and smoking, everything adjusted, the hazard in those who have NAFLD is higher. Let's look at chronic kidney disease. CKD is part of the all NCDs. Those who have NASH, the event-free survival in NAFLD is much lower. In fact, if you look at 5 months, it has started coming down by 25% or so. And if you take it longer, then much higher. So mortality increases in kidney patients with NASH. In fact, it predisposes. Let's look at death in COPD as first cardiac event. Those patients who have fibrosis have lower probability of survival. NAFLD in cancers, very briefly. This very recent publication shows the liver cancer. It will become the second commonest cause of cancers by 2030. It's predicted. NAFLD related. Now, those countries which have liver cancer due to NAFLD as 35 to 40% or so. India tops the world. Liver cancers today in India are not B or C. They are due to NAFLD. You can look at some other neighboring countries where the liver cancer due to NAFLD is much more common. So we need to now wake up. This is the data of WHO Collaborative Center, which we have done national study with 11 centers. Today, etiology of HCC with underlying cirrhosis in about 1,000 patients, diabetes tops. And if you take diabetes along with alcohol, this would make close to 55% or so. B and C are much less than today diabetes. This is from China. If a group of patients, you can see that very large proportion of patients were taken. Those who had an SGPT or ALT above 40, 80 or 120, the people had increased risk of developing. So these were all diabetics. If there is more than threefold rise in ALT, the risk of liver cancers are high. So diabetes and diabetic with high ALT has the highest risk, and we can prevent it if we educate our people who are treating diabetes or managing prevention of diabetes. Look for ALT. In a pre-diabetic, you can prevent a large number of people developing liver cancer. 50% of liver cancers in diabetics do not go through cirrhosis. Let's look at thyroid cancer. The thyroid cancer risk is higher. Overall, higher risk is there in thyroid cancers. Lung cancers, almost higher. Let's look at stomach cancer. The incidence is much higher in these issues. Hence, we need to see all cancers. Prostate cancer is same. So this is my second part of the summary, that fatty liver is core to all NCDs. It includes liver-related complications, malignancies. I have not discussed osteoporosis, sleep apnea, snoring, abdominal obesities, diabetes, cardiovascular, arrhythmia, CKD, polycystic ovaries, stroke, psoriasis. So fatty liver is core to all NCDs today. How to suspect and whom to refer? If we give this to the village level, the worker at the CHC level, that look, we just have to educate them, knowledge. He or she can ask for the person or from him the family history of diabetes, sugar, blood pressure, heart, kidney disease, liver disease, gallstones, cancers, obesity, snoring. Oh, this fellow may have fatty liver. Send to next level. Weight. Just ask the weight or can measure from a weighing scale. Height minus 100. If it is more, the person is overweight. For a female, height minus 105. If there is a feasibility of doing ultrasound, okay. If not, fibroscan, don't worry. Blood, ALT, just blood lipids and sugar. Enough. Now, a very important slide. Is the person or the environment alone to be blamed? I will come to it. First, fatty liver. This is the skin underneath the muscle. This is the fat. The liver is as close to fat. Spleen is black. Liver and spleen should have same gray color, but liver is whiter than the spleen. So this is fat. Fibroscan. This fibroscan is an ultrasound which is low frequency. The sound goes in the tissue for 4 centimeters, comes back. The returned sound is impeded by fat or fibrous tissue. This is controlled attenuation parameter. How much is the sound attenuated on its return? Normal should be less than 250. Above 290 is close to 30-35% of liver fat. This is time in milliseconds. It should take 60 milliseconds for the sound wave to come back. But yes, if it takes less, it is a harder liver. 8.5 means stage 2 to 3 fibrosis. Every overweight or those who eat is not having fatty liver. This is first generation where you can be overweight but still good liver. This is third generation. Here, there is a genetic predisposition. You already have parents or grandparents with this, little bit of overweight, and you are bad. This is just to show you that in this scan, CT scan, red is muscle. Both these people have normal weight. This is 22 BMI, 22 BMI. Here muscles are more, here muscles are less. What is important, this blue is your visceral fat in the abdomen. This visceral fat in a normal is less, much more, 3 times more in this lean. Therefore, lean NASH should also be considered. 20% of our people have NAFLD with lean body composition. This summary is that history, ultrasound, if possible, fibro or CT MRI. Lean person can be metabolically unhealthy. Obese person can be metabolically healthy. Depends on your walking genes. Liver needs priority to prevent NCDs. So a person is underactive, inactive, and eats more will have fatty liver, high ALT, leading to diabetes, high lipids, hypertension, heart disease. Central thought is liver fat precedes, it flames, diabetes and heart diseases and NCDs all have an origin from that. Lifestyle changes, most important is the attitude that liver fat is an alarm and try to diffuse it. We should have a waist to hip ratio, waist of less than 90 and female less than 80. We should all ask our barbers to look for these warts and the necklines. And this is simple for public health screening of fatty liver in the countries. They present with fatigue, sometimes acidity, and most often are without symptoms. This is an important slide. Who has fat in the liver? All diabetics, all overweight and obese. And now lean and normal. For them, you use these criteria of metabolic syndrome of waist, BP, triglycerides, HDL, and others. So all the diabetics must be screened. All the overweight or obese must be screened. Just one word about COVID. We all thought COVID is worse, where you have comorbidities. This is 6.3 odds ratio. But fatty liver disease, this odds ratio is 6.4. There is a high burden. This slide presented by Dr. Manya shows us there is a high burden of complications with NAFLD. Economic burden and costs could be extremely high in these populations. Efforts by India will be discussed by Professor Paul and Dr. Kapil. Just to say that 1 year ago, February 21, 2021, this was launched, NPCDSC, and we are very privileged that India leads the world in this. Today, I would urge Dr. Razia and her whole group of CRO region, non-communicable disease. This humble attempt today is to sensitize the region, whether you can help in developing technical group meetings and policy initiatives. Carry home is fatty liver is core to all NCDs and it needs a priority. I hope I can convince you that globally 1 billion have NAFL, high ALT, Gamma GT didn't discuss. This is another enzyme of liver, directly relates to the cardiac events. So high ALT and a stiff liver is bad. Stiffness above 8. It's the first test today better than a blood test. Your liver is hard, your kidney is hard, your lung is hard, all that. Liver stiffness, therefore, will determine dysfunction of other organs. Diabetes, hypertension, dyslipidemia, CAD, CKD, CV. To win over your NCDs, diabetes NCDs, prevent NAFLD in the future. Thank you for allowing me to present.